Okay, so we have a great speaker today, Dr. Susan Alexander. She is a DNP and also a nurse practitioner. Dr. Alexander is an associate professor at the University of Alabama in Huntsville College of Nursing. Her area of research focuses on the health impact of air quality for vulnerable populations. She works with an interdisciplinary team who is identifying health-related applications for data products of satellite instruments scheduled for launch in 2022, with a particular interest in how the applications can be developed for further use by clinicians, healthcare facilities, and patients. All right, Susan, you may start.
Thank you. So shall I advance the slides or how does this work? Because
So you want to start, see if you can share your screen so that you can take a control on that. But I think that we're going to have a problem with recording if you do that. But let's try it. Let's share your screen and then we go from there. If you can't, then you just tell me next slide and I will move it.
Okay, thank you.
Mhm.
All right. So yeah, all right. So there's our title slide, and I'm not able to. So if you'll go to the next slide.
Okay.
All right. So this presentation is not really meant to address the extensive body of literature that has documented the public health impact of air quality changes. There's lots and lots of very high grade research in that area. My area or my selected healthcare outcomes, my indicators, are specifically emergency department visits and inpatient admissions and then readmissions. And all of those indicators have been linked to reductions in air quality, both nationally and internationally. Dr. Susan Annenberg's group out of George Washington University has done some really, really excellent and strong, robust research about the impact of elevations of PM 2.5 and ozone and the resulting increases in emergency department visits, particularly in children. Inpatient admissions, there's a consistent association has been found for diagnoses such as asthma and elevated nitrogen dioxide in 4 counties across New York. New York is really doing some great research about the local influence of poor air quality for its many different populations and hospitals. And then also for readmissions, the HEAP study that's mentioned in this slide is a European study that was done in 4 countries. And we're beginning to see more and more of that same type of research being done across the United States, because as we all know, there are significant penalties tied to readmissions for hospitals that have those readmission percentages above benchmarks. Next slide, please. Air quality is a very complex topic. We have surface level air quality, and then you have the column that goes all the way to the stratosphere. It's also influenced heavily by how land is used and what sort of vegetation is present in the land. Even in urban areas, there are influences from both prescribed burns and then uncontrolled burns. We've seen those frequently on the news. Some strong studies there about using surface level and remote sensing satellite data to document those influences upon air quality. And then also if you look at the slide on the right, that is exploring the changes in particulate matter that we're seeing across the air in relation to prescribed burns across the country. And you can see that the Midwest has really had some pretty strong influences, elevations in particulate matter because of the burns and then the smoke plumes that actually even come up sometimes from Central and South America. Next slide. So my interest at this point has to do with health outcomes in Alabama, for a couple of reasons. When I first began work with this team, I was approached by them in an effort to acquire health data. And they have science data, NASA data, satellite data that is freely available. You don't have to get IRB approval to use it. You don't have to pay for it. You can just go, if you can find it and find a source, there's usually a platform that will help you get what you want. There may be somebody to help you write your query, those kinds of things. And we all know that health data is not as freely available. And so the first data set that I purchased with funding was from Healthcare Cost and Utilization Project. I bought several years of data, and you probably all know that HCUP is a project that's maintained by the Agency for Healthcare Quality and Research. And then HCUP data was first begun to be collected in about 1988. It has expanded to include an annual 20% sample of inpatient discharges, emergency department visits, readmissions, and then there's some pediatric inpatient sets that you can get from states across the country. At this point, there are 2 states that do not contribute data to the HCUP set, and that would be Alabama, and the other one is Idaho. So it has proved to be not a simple task to get healthcare data for the state of Alabama. I have worked with one of our local quality improvement, or our state quality improvement organization, and I have been able to get data for adults who are CMS beneficiaries, dual eligible, and fee for service. I don't have Medicare Advantage, but it's a very sizable population, and so that's where I have begun my study, and have begun with just trying to have a targeted approach. And I'll explain why that's my focus when we talk about the tempo data, because I want to understand where geographically these populations of folks who are experiencing more admissions and more ER visits and more emergency readmissions are actually living, where are they residing? And so this data source was a great way to do that. I have about 5 years of data on the Medicare beneficiaries, and fiscal year 2014 through fiscal year 2018, I think at last count 56 months of data. And so I've been able to determine, just doing some preliminary analysis, the counties that have in which more residents, or excuse me, let me try to phrase this correctly. So the top 10 counties that had the highest numbers of total Medicare admissions for any reason across the state, I have those. Top 10 counties for total numbers of readmissions. And then I've also looked at the source counties for those 5 most common disorders that result in inpatient admissions. And they're not quite all the same. There are some pretty strong similarities, but it's a really good way to help us understand maybe where we might want to really drill down and try to get more discrete air and health quality data. Next slide. So here are my basic research questions. I'm looking at temporal variations that exist for my health indicators across the state of Alabama. For what diagnoses and or counties are these variations occurring most commonly, and are they statistically significant? How do these results compare to national benchmarks? What factors predict the temporal variations, the seasonal variations that we're seeing? And then again, what is the role of the very localized air quality, both in terms of single and multi-pollutant mixtures, in predicting and explaining these temporal and seasonal variations that we see in utilization of these healthcare services like admissions and ER visits and readmissions? Next slide. This is an example of some preliminary work that we have done, and I've tried to remove the name of the county and the years, just because I will be using this in a publication. But this is a time series statistical process control chart with those 56 monthly data points that demonstrate the proportion of admissions for respiratory disorders using major diagnostic categories for this particular county and across that time span. And you can see the bold line between the two dotted lines is the average, and that would be the state average for the respiratory admissions for the whole time frame, and then the upper limits of control and the lower limits of control. So you can very clearly see where that particular county had more residents being admitted for respiratory disorders. Next slide. This is another example. This is hospital admissions by county. This is total hospital admissions for a particular county in comparison to other counties. And this is one of those that was on the top 10 list using that same approach. And so you can clearly see that along, I'm not sure if you can see my cursor, there's kind of a flat line until it really begins to elevate along about August or September of a particular year. It stays up and then sort of starts to drop off. Why is that? Not really sure, but it's a good question. It's a good, perhaps, area to further explore. This peak that's on the right, if you look at, it starts at June and goes to about September. I do not have an explanation for that peak, but I can tell you that that very same peak was seen in almost all counties for this particular, for hospital admissions. And so it was not during the time in which we transitioned from ICD-9 to ICD-10. So it does not seem to be related to that particular coding experience. But we have seen that peak in every county that in using this process. So my biostatistician and I are continuing to investigate that. We have not yet been able to determine an explanation really that satisfies either one of us. So next slide. And again, respiratory admissions as a percentage of total hospital admissions for a particular county. You can clearly see where this county is above not only benchmarks, but the upper limits of control for sustained periods of time. And you can see that it does appear to be seasonal. Begins long about October, persists until April when it returns to the benchmark. Next October, November starts to climb again. Next April or May. So these are phenomena that we see in clinical practice. We understand that there are certain times of the year we've witnessed this, that folks present to emergency departments or hospitals for admission who have cardiopulmonary conditions, and they are worsened for lots of factors. But there's probably, I think we underestimate the influence of environmental factors that lead to these seasonal variations. Temperature, yes, obviously that's a very important concern. Humidity is another one, but air quality can also be an explanation that I think we probably need to explore perhaps more than we have. Next slide. All right, so enter tempo. And this is a screenshot of their homepage. Tempo means tropospheric emissions monitoring of pollution. So NASA likes to use acronyms for lots of things. They have their whole jargon that is used in NASA that I'm still trying to become accustomed to. I'm better than I was. It's almost like a little bit of a different dialect. But this is a graphic overview of the TEMPO mission. So TEMPO is significant for a couple of reasons. It is going to be a geostationary instrument. It has been built. And the contract for its launch has just been settled. We do know that it's going to be launched sometime within the first 6 months of 2022, and that will be narrowed down as we get a little closer to that date. Obviously, weather and those kinds of things are going to play a factor in the launch date. Tempo will collect data on criteria, air pollutants, aerosols, and gases, and some of the precursors that are used in the formation of ozone at surface level. hourly across the North American continent. We'll get a little bit of Canada, a little bit of Mexico, but hourly during daylight hours at a spatial resolution of about 2 by 4 kilometers. So 75% of the satellite's time is going to collect data at that resolution. The remaining 25% of the satellite's time can be requested for sort of a finer capture, a closer look, as it were, and it can be configured to collect these data measurements every 5 minutes at a spatial resolution of somewhere around 1 by 1 kilometer. So it's very, very tight. It's going to generate mounds and mounds of data, and to compare it to what we have now, its ancestor is OMI, which is still in orbit, still collecting data. OMI is a polar orbiting instrument that gets one measurement a day, every 12 hours. So we are going to have a better understanding of factors, air quality factors that go into what we are actually breathing at the surface, better than we ever have in history. There are a couple of sister instruments that are actually already in launch in Asia and Europe, so TEMPO will be the last of the triplet. So, next slide. Here is a list of what TEMPO will collect hourly. This hourly observations are standard. Again, if someone's doing a project in a specific area and says, I need data every 5 minutes, every 10 minutes, and can give sufficient justification to make those changes, that can also happen. So you've got your tropospheric ozone, formaldehyde, NOx species, sulfur dioxide, glyoxal, and that's supposed to be H2. It's not water. It's supposed to be, oh shoot. Okay. It's a hydrogen species. Halogen, aerosols, clouds, and ultraviolet B radiation. But again, that's all listed on that mission overview site. So some of these are precursors also that go into the ozone formation of ozone and other species. Next. So what will TEMPO do for us? Well, again, it's going to really improve the accuracy of our current measurements and our current calculations. If you know very much about air quality index and air quality models, they're typically a combination of the surface measurements, ground level measurements captured at monitoring sites across the United States, and then satellite remote sensing data. And then, so you have the real numbers, the real measurements as much as possible, and past that is extrapolated using a model. And these models, depending on their location, that they're predicting air quality, and they can be quite robust and quite accurate, but they're still models. So we will have much more real data collection to contribute to these models to strengthen them, or maybe even create new models. Aerosol optical depth is one way that the surface level of various criteria air pollutants is captured. So it will help to, it's a mathematical calculation that's created based on various satellite and land surface measurements, so it will improve that accuracy. And it's also these very robust TEMPO data collection parameters will help us better characterize and document exceptional events that may occur, whether those are wildfires, smoke plumes, dust storms, volcanoes, elevations in pollutants because of other sources. It's this kind of very discrete data that's really going to give us the best picture of what those influences and sources are, better than any that we've had in the past. Next slide. This visualization comes from NASA SPORT. So SPORT is an agency connected with NASA that supports their research data to operations paradigm. So you can go to SPORT, they have their website, and there are some really interesting visualizations, and you can run some of their pre-programmed queries, or you can work with SPORT to design your own. This is the field of regard, FOR, for TEMPO over the CONUS. And every time they say the word CONUS, it makes me want to think of something more anatomical. But this is for nitrogen dioxide. This is for 1 day, September the 13th of 2013. Now, CONUS is not, TEMPO is not yet in orbit. So this slide may be a little bit confusing because you're thinking, wait, TEMPO's hasn't even been launched. How can we be getting these data for the TEMPO field of regard? So NASA is very interested in and has invested a lot of resources into the pre-launch phase, the planning of how can we want to be able to use these data as quickly as we can post-launch. So for what applications can we identify that they would be useful? What do the file formats need to look like? How will we house these? What platforms, what tools will we use for academic researchers, exposure assessment researchers, epidemiologists, and also end users in healthcare, which is our group. So this is actually a looping, I believe this is a looping image. And Azita, if you have the slide deck up, you may be able to find there's an arrow on the left side that can actually play that visualization. I don't know if you can do that, if you can see it. I can't on my screen.
Susan, we don't have that, I think.
Okay. All right. Well, that's fine. Well, I will just, let me just, again, this is 1 day, simulated day using TEMPO, what the TEMPO data would look like based on real data that we already have for September the 7th. And you can see during that day, that actually 8-hour period, it's not 24 hours, it's 8-hour period, where the hot spots are for where the nitrogen dioxide levels are exceeding standards for that area. And if you look at Alabama, here is one area. This is along about Jefferson County, Shelby County areas. Next slide. So this is a comparison. This is the same day, and this is a focused view over the state of California, which has lots of issues with poor air quality. And on the right, the title is OMI, which is a current satellite, NOx retrievals. That's what we presently have. And then on the left, we have NOx retrievals that we would anticipate available from TEMPO data for that same day. And so Aaron Nager, who was kind enough to create the slide and allow me to use it, has placed them side by side so you can see very, very quickly and you can appreciate the resolution that TEMPO will give us and help us see influences and elevations that are just simply not presently available with OMI in our current retrievals. Next slide. This is the same day. If you remember the country slide, the USA, the slide that we saw, there was an area over the state, central Alabama, that had some elevations. And so Aaron created a diagram with the state of Alabama. There's counties in Alabama, and this pinpoints exactly where that elevation occurred, the nitrogen dioxide elevation occurred. And on the right-hand side, the gradients are a little bit different. So it looks brighter here, both because of this sharper focus and because he configured it according to what local standards were. We think that the source could be, because this was seen on OMI data too. It was just reconfigured using TEMPO proxy data. So we think the source could have been from a coal plant that's located in Shelby County. Don't know that to be the case, but again, this is 8 hours, 1 day, and this is kind of very sharp and precise resolution that we'll be able to see using TEMPO. Next slide. So for the purposes of my project and my research, we're going to work with TEMPO data that has been spatially interpolated to the county level. And I chose this because in working with hospital partners across the state, counties are much more stable over time. If you've worked with geographical data, zip codes, a county can have several zip codes, or it can have only a couple, it can have lots and lots, but zip codes are not stable. They change according to census data. And so we have chosen to use at this point county data because for the purposes of our time frame, it's the most stable way to frame that for our work. And again, this is just an example of the images that we'll be receiving for Alabama County data. Next slide. This is currently what's available using OMI satellite. So you can see that the grids, it's a gridded approach, and those grids that are exemplified by those dotted lines that crisscross the state cover some relatively large geographic areas, and they have very little relationship to counties. So for the purposes of my health research, gridding it to the county level is going to be much more helpful. Next slide. All right, so as I said, NASA is very deeply invested into pre-launch activities for Tempo. At this point, I've been able to help somewhat play a role in testing the data processing infrastructure. There are different platforms for which this data will be available for wide use, and I'm working on a particular platform with a cloud, publicly available cloud vendor. And another example of pre-launch activities is to understand how those data can be assimilated into our current model. So they're working with the Proxy data products to kind of work out the bugs. So again, when Tempo launches, we can capture and begin to use that data as quickly as possible. When everything is in place and going, Tempo streaming data is expected to have a latency of 2 hours or less. That's their target. Probably won't be quite that tight at first, but very quickly, a 2-hour latency. And then be able to understand and ready to plug in these Tempo data for some use cases, some applications as quickly post-launch as we can. So I'm going to be incorporating those into some work that I hope to do within the state, or I will be doing in the state, for a couple of reasons. I would very much like to be able to help facilities predict what they might be able to expect in terms of these health indicators, and to create some models that consider air quality as a factor. And then also to be able to build actionable insights that can help our patients, us as clinicians and providers in our facilities really be able to mitigate the impact of poor air quality perhaps better than what we presently have. Next slide. I am working with Google Cloud Platform and Onyx, that is a reseller that works with Google. And so in keeping the theme of using the synthetic data, we are not only working with Tempo synthetic data, we are working with synthetic health data, simply because the file format for this health data source very closely matches file formats that are seen in clinical electronic health record systems in place across the country. And so we're trying to understand how we can fuse data from those two sources. What does it take in terms of attributes within the data sets, and then the tools and the platforms that can be used to build that and to make it an ongoing process. So this diagram is one that was given to me, or it's in process by one of the Onyx Solutions engineers. His name is Tim Tenerillo, and I'm thankful for his help. And so this is, again, state of Alabama. The green spaces, the green areas, are cases of, as an example, viral sinusitis. And so in the synthetic health data set that I was able to obtain, this was one of the most common diagnoses. So we decided to start with it. And where the patients who presented for care either to a hospital, an emergency room, or a practice of some kind, because the data set included NPIs for all of those with latitude and longitude, were latitude and longitude for those patients. And this was actually based on zip codes, simulated zip codes. And so the red dots are areas in which the air pollutant that was studied were had exceedances for that particular time frame, which was this was a year. So this, again, is just our beginning exploration of how to work with these data. The larger the dot, the greater the geographical diameter that had prolonged elevation in criteria air pollutant. I think in this case it was NOx species, or maybe sulfur dioxide. And then the darker red indicates, because if you look, you can see some of the red circles have little darker spots in them, where the darker the color indicates a greater exceedance in that area of that criteria air pollutant. So this is an example of something that I would like at some point for end users to be able to access the platform that we're constructing to do on their own. We're not there yet, but we're moving that direction. Next slide. So our next steps in this project will be to not only utilize the tempo data that will be available, but to match or to combine this with data that we're from some lower cost surface level environmental air quality monitors that are going to be placed at locations over the state. And we actually have several of these monitors. We use a company called Aerosols for most of the gases, and then we'll be looking also capturing particulate matter 2.5 microns or less using a different company. But so these monitors will be mounted, probably co-located with some existing climatological weather monitoring stations across the state, and at sites like hopefully hospitals. I've got a couple of hospital partners that are interested in coming on board with the project. The Department of Transportation, different areas, such that, again, we're really creating this test bed that's going to use this newer satellite remote sensing data in combination with the ground level data to help us understand what's happening at much finer geographic points. It's all that we need from a participating partner. It would be a place to mount the sensor box at a certain elevation. We need Wi-Fi access from the partners, such that the measurement data can be streamed to our storage area in our platform. And hopefully some of our partners, particularly those that are healthcare facilities, would be willing to provide some patient level data about these selected indicators of interest, so that we can, again, continue to try to fuse those data sets and help these facilities better understand what they experience as a result of reduced air quality. Next slide. Maya is another instrument scheduled to launch at roughly the same time that Tempo is, and I've included this as a last-minute late-breaking news. So Maya means multi-angular imager for aerosols. So if you remember, Tempo is geostationary. Maya is a polar orbiting instrument, so it will be capturing international data. This is a link that I have included to their mission overview page. This is a significant event, the launch of this satellite, because it's the first time that the partnership with epidemiologists, health organizations, has really been solidified by NASA in addressing the need to use these space-based data to study the influence of air quality changes upon human health. We expect that Maya will really, really broaden our understanding of particulate matter, the size of the components, the speciation, various emission sources, and will be used specifically for projects that are within these particular categories, such as adverse birth outcomes, cardiopulmonary disease, and premature death. Maya is not quite as far along in the pre-launch phase in terms of data creation, data planning, but they're getting there quickly, and so we look forward to working with the the groups, the scientists from that group, to understand better what the influence, again, not only of gases, but of particulate matter will be on human health. I'm really excited by this because Maya's approach for their monitoring, considering that they're a polar orbiting satellite, is to identify areas that they consider primary target areas and then secondary target areas. And so these target areas have to meet particular specifications in terms of geographic size, population, some of the demographics, the availability of healthcare data, the availability of surface level monitoring, and that kinds of thing. So just about less than a month ago, we found out that in addition to the Atlanta and Central Georgia, North Georgia area, most of North Alabama from about Birmingham north to the Huntsville, just north of the Huntsville area, would be included as a primary target area for Maya. So this is really, really great news for us as a state, and I'm really gratified to see that as someone who's interested in health and air quality research. Next slide. So I want to thank these organizations that have sponsored our work in identifying how tempo data can be applied to healthcare use cases, and have supplied data and funding and man hours, and will continue to do so in this effort. And so here's just an example of some of our sources. Next slide.
There's no more.
That's the end of it. Okay, we're done. That was right on time. I did not forgot to put this in, but I sent, or you probably received in your email, a notice about the conference that's being held October the 10th here at UAH on the subject of applying tempo data in healthcare applications. So I'd love to have anyone who's interested in attending that conference just come on. Lots of nurses will be there who really don't have a lot of depth in air quality and public health research, but that's fine. This is very much a discussion, brainstorming kind of opportunity, and these groups want to hear from end users who have clinical insight about how these data can be used and why they would be important.
Thank you so much.
You're welcome.
That was great. I have a quick question. So you said that tempo, one of the pollutions that it measures is aerosols. Do you know how detailed they can go in differentiation of aerosols, like particulate matters, different sizes? Is it able to do that, or it's gonna give us a, just an overview of the combined aerosols?
You can find more information about that on the Tempo Mission Overview site. Particulate matter is not assessment of particulate matter, I think, is more within the strategies of Maya, but what tempo will capture will be used in calculation, somehow aerosol optical depth. So the answer is no, I can't quite explain that, but the information is there on the mission overview. And it may be that what happens is the data that are captured are used in processing to generate a PM assessment parameter. That's the best answer that I can give you.
No problem. Thank you. Any other questions we have from audience? Jessica, Luz, Lacey, do you all have any questions?
Well, certainly. Thank you. This is Jessica. Thank you for this very interesting presentation. I have a methods question and a few application questions.
All right.
So the methods question is, I've read that some of the uncertainty in using this type of exposure modeling can be tied to the age of the satellite. How does that enter into your consideration in your work?
Well, tempo will be brand new. You know, it's the planned life of Tempo and the mission is 3 years, but it may well be longer than that. So for the present work with Tempo, can't say that it really does. Once we get past the 3-year hurdle, I guess that would definitely be something to consider at that point.
Thank you. And just to let you know, I'm the editor-in-chief of the Journal of Emergency Nursing. And we're looking to have a collection of environmental health papers for probably July of 2020. So submissions by the beginning of the year are most welcomed, particularly because you are using emergency visits. And if you can speak to the emergency nurse managers in staffing considerations or injury prevention, that's most welcomed.
Oh, thank you.
Certainly. And I'd be happy to send you a few papers that I worked with on my team. That map fascinated me because of the two very red areas on the national map. I grew up just downwind of one of them, and I'm raising my children just downwind of another one. So an interesting place of interesting location, but we really looked at having to control for outliers in the time series in some of our data, particularly because when we were looking at emergency respiratory visits, we had concerns, of course, with infectious disease season and the year that H1N1 flu epidemic. We really saw a signal in our data. So talk to me about how you're in that time series, how you're going to look into those both step changes in the time series, because it looks like you've done a descriptive analysis. So how are you looking at step functions, and how are you looking at those point outliers?
Well, this is our preliminary work. And so from the health data that I have, I have read about, confounders and socioeconomic status, smoking, those kinds of things. And other than in my CMS data, other than geographic location, I can't capture those other confounders. So at this point, I cannot, but hopefully when we can get some patient level data that really accounts for those factors that may increase risk, such as smoking or age or whatever, we will be able to do that. But that, that's very hard, right? It's just with the health data that we have, because the CMS data that I have is claims-based. It's administrative data. It's not clinical data. Now, the simulated data set is clinical data, and it doesn't capture things like smoking, but it certainly could, if you had true patient-level data. But that's a great question, and we are still trying to arrive at an answer. At this point in Alabama, using that CMS data, I'm glad to have what we have in terms of looking at those long-term variations in admissions and so forth. But for more focused analysis that we hope Tempo will support, then I really just can't tell you at this point. It's all kinds of, it's a good topic for discussion, and it's why I need folks like Susan Annenberg's group and those others to weigh in on how you account for those confounders. Sorry, I can't give you a better answer.
Oh no, that's wonderful. I'll send you some papers, and
Okay.
we'll be happy to exchange ideas going forward about some of the methods.
That'd be great.
Okay, wonderful, and thank you for the presentation.
You're very welcome. Very welcome. Other questions?
No more questions. I think I just appreciate your time, Susan, again, and also all of you who attended this meeting. And we're looking forward to see your work in print and in publication, Susan.
Thank you. Thank you. Please don't hesitate to give me a call if I can help.
Yeah. Sure. Bye, everyone.
Bye-bye.